Yasmin Rashid. And there I wanted to be a gynecologist, but I ended up being the gynecologist for men. Okay. And in 2005-6, I did my house job at East Medical Ward, Mayo Hospital, where Dr. Javed was our professor and Dr. Somia was our registrar. So that's my introduction to you people. Okay. So I do not have a financial conflict yet, but this is one thing, well, which is marred with this financial conflicts and all over the world. I hope that doesn't become the problem in our part of the world. It is already there, but probably one should avoid it. Okay. It's a big market. As mentioned, in all over the world, it's $1 billion market, and Pakistan is just introducing it, and there is a historical reason for it. I would address that. I do not have any political affiliation, because when I hit the history, I was a bit concerned that Vigo dala hi na aa jaye. Anyways. And most of the images and media I would use for BD. Okay. So the question, and I would prompt my panelists in between for the questions. Is the time is ripe for this discussion? Maybe Dr. Javed, you may have some comments. The psychologists, I think they are the people who have the insight in the psyche of the society, or maybe the internal medicine. What's your comment, sir? Okay, do you think it's the right time that we openly discuss among ourselves, A, and secondly, with our patients?
अगर आज ना डिस्कस किया तो फिर कब किया?
हाँ, क्या बात है सर, क्या बात है. हाँ, the time is always right. But I would really like, what do you think, why we exactly do not address it? Maybe we do address at times among ourselves, but not with our patient. So probably what I have found, mostly the reason is time. A psychiatrist, he would know, you enter this area and you are done with 15-20 minutes. You are an endocrinologist or a family physician, and you ask the question. I usually ask to start the problem, I say, कि wife से ताल्लुकात सब ठीक हैं. You ask this question and you are gone for like next 10 minutes. So that's one of the practical reasons why we don't discuss with our patients. But, and this is from European perspective. The European Society of Sexual Medicine, they were discussing this recently rather, that it is a patient safety issue. And why exactly? And you guys know this pathophysiology better than me. The hyperlipidemia and diabetes, this causes atherosclerosis. What one should consider, there is something known as artery size hypothesis. The smaller the arteries, and earlier they get blocked. Not exactly in these sequence at time, but mostly. Say for example, if you have a person who is 40 plus years of age and comes with myocardial infarction, you would not be surprised. Now even at 38 years of age, you would probably not be surprised. So why you are surprised if a person is 30, 35 years of age and he has some erectile dysfunction, and why exactly you want to label him with some psychiatric problem? Okay. This is quite an established fact. People have done studies like when doing angiography, you do an angiography of the penile and cavernosal artery. More often than not, you find an equivalent plaque there. Okay. So if we are the guardians of society, and that's how we define health, then this is an important area we are not addressing for many practical reasons. The patients we see in our clinics, I sort of divide them in these syndromes. One is this guy who has a clear-cut metabolic syndrome, and more often than not, and I would tell you, like, I have a practice of advising as baseline HbA1c and lipid profile, and probably I have diagnosed at least one patient with diabetes per week. That's how common it is. And second would be this guy, who have some metabolic as well as work-related stress, and third would be this guy. And this is becoming quite common, and who has just searched on the internet and some wild ideas about it. Okay, what we can offer to these patients? The current status is something like this. We all use it. Any comment about it, especially from our physicians? We all use it. our endocrinologist. I myself have prescribed similar things. Any comments about it, sir? Okay. Okay. The placebo effect. Exactly. That's why. If you just want to reassure the patient, we all know that it doesn't do anything. And when I prescribe something like this, I'm not anything different from this guy. One of the factor behind is what I call as Viagra phobia. And we all have this phobia because of multiple reasons. One reason which was briefly addressed there, that it was not until recently officially available in Pakistan. Then there are multiple news like this you would hear on and off, and that would further increase this phobia. So when I heard this news, I was quite excited that Pakistan is entering a new era. But the history of it, that we do not learn from the history. So this discovery led to the Nobel Prize in 98. Viagra was available officially around the same time, 98, 99. And at the same time, it was banned in Pakistan. The historical reason was, at that time, if you remember, in 1999, who was in government, and we did not want to sort of, जो मौलवियों को हम वो नहीं करना चाहते थे, नाराज नहीं करना चाहते थे. That was the simple reason for it, put it bluntly. I hope that is not the situation today, but I am a bit skeptical. Okay, so you can talk about the history of this drug development, but I would not bore you with the details, but I would hit one point. Recently, in NHS, when this was initially available in NHS around 2005-06, then they banned it for an off-label use or for to be prescribed without any workup by the general practitioners, because the fear was not of the safety of the medicine, but that if you prescribe them without workup, you would missing the diabetes, the endocrine disorders, and the underlying metabolic syndromes. But now that situation has changed, and currently it has been approved to be prescribed from the pharmacy itself. If you just fill a small form, you can take it directly from the pharmacy. The reason is, in NHS settings, they do not want to overburden their own institute, that patient have to go to a GP or to a urologist, get the workup, and then get the prescribed medicine, because it's quite a commonly used medicine. Okay, from our patient's perspective, that's another perspective why we have this Viagra phobia. The patient doesn't want Viagra. The patient doesn't want sildenafil. He wants something which keeps him young for life. वो अभी कह रहे थे ना कि मर्द तो हमेशा पता नहीं वो खुशी नहीं होता. That same is true for females as well, so we are never satisfied. But there are objective ways of describing erectile dysfunction. So the medical equivalent of this is something like this, regenerative medicine. People have tried PRP therapy or ultrasound shockwave therapy. The basic aim of these therapies is you want to regenerate some stem cells. But seriously speaking, this stem cell research, it is theoretically it's promising, practically it's nowhere. And I would really like Dr. Waqar to just correct me if I am wrong. We see organ failures like heart failures, liver failures, and renal failures. And brain failure, dementia, maybe you can call something like brain failure. Bladder failure, like neurogenic bladders. But what about penile failure and testicular failure? So erectile dysfunction, how I visualize it, is essentially a failure. And how you manage a failure? You address the underlying risk factors, and meanwhile, you do something to improve the function. So you can address the underlying risk factors, personal as well as environmental, but that's what usually happens. So that's why we just write the placebo. Okay. One of the factor behind so-called Viagra phobia is lack of, I would not say knowledge, but practical experience with these medications, because these were not officially available, and there was a lot of उसके around एक aura सा एक है ना, तो we do not. होता क्या है कि when you start prescribing some medicine, you become more comfortable with it. I remember 10 years down the line, people were not very comfortable comfortable with alpha blockers. But now, at times, every patient with lower unit X symptoms, he would get a prescription of alpha blockers. Okay. Regarding the different medications, there are little difference. Practically speaking, there are little different among them in terms of efficacy. There are some difference in terms of side effects. The major problem with these medications in terms of side effects is headache. और मरीज को लगता है कि शायद मेरा ब्लड प्रेशर बढ़ गया और बस मुझे ऐसी दवाई दे दी है, मेरा तो सर फट जाएगा. So I usually address them like telling them कि start with the lower dose, 50 mg for the sildenafil, or usually it is lesser with the tadalafil. Second is some people don't like that you have to take the medicine just before the activity because many a times it's not a planned activity. Imagine for the sildenafil, the recommendation is that you have to take it on an empty stomach. Now imagine a person who had a late night dinner on a Saturday night at 10, 11 o'clock, and you are home at 12, and now you are waiting for your stomach to be emptied. So it's a real practical problem with sildenafil. The other option is for tadalafil, but the major difference is that of cost. So I would stop here and ask our panelists to add to the discussion. Thank you.
Assalamu alaikum. Thank you, Wajahat. Quite enlightenment there. I think basic issue is the patient does not want to come to us. The first line is the family physician. And most of the time he remains there. And the problem sometimes is much more than a lifestyle modification or giving them a placebo. I think it comes to us when there's a really acute problem there, when they're unable to perform properly. I think one of the causes being a venous leakage. And we tend to see quite a lot in younger patients, and which is not curable by any medications and need a proper diagnosis. Regarding erectile dysfunction in an elderly or a middle-aged man, I think the lifestyle modification helps, and the PD5 has a real role in those patients to begin with. Yeah. Thank you.
Thank you, Wajahat, for an excellent talk. My concern as a nephrologist, of course, is that the moment, a patient of mine of CKD comes to me with ED, my concern is that let's hope and pray that next iska koi myocardial infarction na ho, because that's a marker for, coronary artery disease. So that is my main concern. Of course, we all know that ED in CKD patients or even otherwise is multifactorial. बहुत सारे factors हैं और जो कि play an important role. Unfortunately, to me as a nephrologist, all the studies on ED have been carried on in dialysis and transplant patients. Very few studies have been carried on in CKD patients or pre-dialysis patients. But of course, our serious concern and of course, PD5 inhibitors play a role, and that is probably the only option that we have in these patients, and we've tried. But again, यहाँ पे I'll be very honest and frank, यहाँ पे हमेशा में यही concern रहती है कि the drug that we are giving to this patient, is it genuine or not? ये कोई number 2 तो नहीं है. But that's our concern. But okay. And of course, there are other important factors which need to be corrected. अगर CKD patient का hyperparathyroidism की वजह से हो रहा है, anemia can cause ED in these patients, and some people have reported very good results with the correction of the anemia with erythropoietin. So there are as I said, the cause of ED is multifactorial, and you have to look into that particular patient as to what is the leading cause of ED in this particular patient. But of course, and everybody's concern is that this is a marker for coronary artery disease. Okay. Thank you.
2 points I would add to Dr. Aziz. Yes, you are very right that ideally the patient should travel from the physician and then to the specialist, but that is probably would happen in a country where primary health structure is there. In our population, what happens many a times, patient just Google and he finds out that the urologist is the person to go, and you end up diagnosing the diabetes or even psychiatric illnesses commonly. So we refer back them to the physician. That's one. Regarding the concern of Viagra se gurde kharab ho jate hain. Okay. That's common. And that's how I address it. The problem is the underlying disease. वो तो शुगर की दवाइयों से भी गुर्दे खराब हो जाते हैं, है ना? वो ये भी सुना होगा आपने, इंसुलिन से भी गुर्दे खराब हो जाते हैं. The problem is the underlying factor is the same. So that's how I tell them that if you are having erectile dysfunction and some other problems as well, like diabetes or CKD or ischemic heart disease, the problem is not the use of Viagra itself. The problem is the underlying factors are the same. Regarding the safety of these medications, for creatinine clearance, there is not an issue because the clearance is mostly hepatic. For liver failure, it's an issue. But for most of these patients, if you are reluctant for these, use the half of the dose. Like for sildenafil, it would be 50 milligram. The only precaution which was very concerning was the use of PD5 inhibitor with nitrates. But you people know it better than me. Currently, the nitrates are not very commonly prescribed, thanks to the success of angioplasties and all. बहुत कम होता है ऐसा कि nitrates पे patient हो, but still, ये एक बड़ा मसला है. Whenever I am prescribing, I have to go through the list of medicine और वो अलग-अलग नामों से होती हैं, तो you don't know which one can be the nitrates. But fortunately, अब nitrates बहुत कम prescribe होने लगी हैं. Sir.
Okay. Thank you. First of all, a big praise to the speaker. Being a medical educationist, whenever I stick to a talk, I always go for my tick. Acha, ye kiya. You did really well. Okay. As far as being an endocrinologist is concerned, we all know that currently Pakistan is leading the world as far as prevalence of diabetes is concerned. We are talking about 1/4 of world population. And if we talk about the prevalence of ED in diabetes, it's around 35% to 85%. So if we talk about ED, it means we are talking about around half of the Pakistani population. Now, diabetes is a tricky disease. If we look at the ED mechanism or pathophysiology, you have got hormone, you have got nerves, you have got vessels, and you have got brain. And problem with diabetes ED is that diabetes is going to affect each and everything. It's going to affect your vessels, it's going to affect your nerves, it's going to affect your hormones. Probably that's the reason diabetes ED is the most stubborn one to control. And it's a really good news because if we are talking about 1/3 or half of the Pakistani population who are suffering from EDs and ED because of diabetes, and we didn't have any drug. Coenzyme Q10 and tribulus and all these things, though these have got some effect, more than placebo effect, we all know that, but we don't know that what on long term these drugs are going to do with our patients. So we were so much scared when prescribing that. Now we have got a drug which is proven and which has got evidence-based medicine on back of that. So I think it's a wonderful drug. But we should use it cautiously. As Sir said that GFR is definitely a limiting factor. For example, if we're talking about less than 50, you cannot give tadalafil more than 10 mg. And if your GFR is less than 30, you cannot give it, it's 5 mg. And that 5 mg should be given after 72 hours. So if you are practicing evidence-based medicine, you should know all these things, that which patient to give which dose and which patient to give a drug in 3 days or 2 days or 4 days. But I think it's a wonderful drug. And again, a praise for our speaker. Thank you.
Excellent talk, Wajahat. Congratulations for a wonderful talk on a very common issue and a practical issue. I personally, as a practicing physician, think that this is often not diagnosed, erectile dysfunction, unless you specifically ask the people. Because of our social setup, there are inhibitions and people don't feel comfortable talking with it, especially if they are accompanied by family. So that is number one. Number two, to me, obviously my worthy colleagues discussed the best options possible, and you yourself highlighted that, that most of the erectile dysfunction is misconceived. people, when I ask them what's the problem, it's physiology and not pathology. They say early ejaculation, but how early? It's all mostly in the mind to me. That is there a normal time duration for ejaculation? No, it's a very relative thing. You know, it's how many times and when was the last activity done. The time of ejaculation also depends upon this. So I think the most important tool that we have, phosphodiesterase inhibitors, everything is fine, aspirin, is the time with the patient. That is extremely important in every disease. Counseling, talking to them alone if required, and explaining to them that what you are experiencing is just normal and be satisfied with it. And usually with your counseling, counseling works better than any pill. Thank you.
I would add a couple of things to this. That one is that there is a nice questionnaire, International Index of Erectile Function, which was translated by Dr. Khaliqur Rahman into Urdu. If you just go through it, and you would know how to assess whether it's exactly an erectile dysfunction. You don't have to necessarily put the question, or it's something else. So very rightly said, regarding the use of PD5 inhibitor and the patients on creatinine clearance, you need to be very careful. You need to be very careful while prescribing this medicine. But one point I would want to add, that the role of these medicines is just like a painkiller. It is just addressing the symptoms of the disease, or a sleep medication. Nothing more than that. The underlying factor is definitely something else. Sir.
As a physician, I think many people come to us, they have comorbids, they are without comorbids, and age is also a very important factor. People have 70 or coming to you and saying we have erectile dysfunction is quite different from somebody who is a younger person and coming around here. The problems often present as people are confused as to what ED really means. Many people come, they have lack of libido. The others come who have lack of orgasm. The third is early discharge. The fourth is they have lack of sustained erection. So these are all different things, and people come with different, it's not necessarily one ED they come with. And many of them are psychosomatic disorders, and many of them. So I think we have to really, as Dr. Akram said, take a detailed history, also do hormone profiles, also do other checkups to look at the comorbids, and then come to conclusion whether the person will benefit from PD5 or not.
Exactly. So you need to do this. Just adding one thing, what I have found in my practice, the most useful thing is that you ask the wife. She would tell you the exact situation. Many a time the person is worried and the wife is not worried. So that would take care of 90% of the problems. So that is very, very useful. Sir.
जुल्म कर दिया सर, आखिर में वाला सवाल पूछ के आपके वाइफ से पूछ लें. खैर, एक मेरा नाम डॉक्टर जावेद है. अगर कोई बात ऐसे कुछ कर दूं तो उसके लिए माजरत चाहता हूं. पहले सिर्फ ये पूछना चाह रहा हूं, हमारे असातिज़ा बैठे हुए हैं, बाकी साथी हैं, कितने लोग अपनी क्लिनिक्स में ईडी या सेक्सुअल डिसफंक्शन के पेशेंट्स देखते हैं? ठीक है, सारे देखते हैं, फर्स्ट क्लास. ठीक है, अच्छा.
I see it. In my practice, 80 to 90% of the patients.
पेशावर में ईडी की डेफिनेशन थोड़ी सी फर्क है.
ठीक है. अब यहाँ पे सवाल ये पैदा हो जाता है कि पैथोलॉजिकल कॉजेज और जो भी बाकी इश्यूज हैं वो आप हमसे बेहतर जानते हैं, आप सारी चीज़ें देख रहे हैं. डॉक्टर साहब ने एक तरफ निशानदेही की कि वक्त नहीं है, तो महदूद वक्त में फिर क्या सवालात करके आप ये देख लेते हैं कि हाँ चलें ये चीज़ जो है वो नहीं है ऑर्गेनिक, साइकोलॉजिकल कॉज है, तो उस महदूद वक्त में क्या कर लेते हैं?
Okay. The key question to ask, which I do, is onset and duration. If it's a recent onset, and as well as there are other factors surrounding it. And second is you ask the wife, she would say, most of the time he is fine. He's just worried nowadays.
देखें, ये तो आप, ये बिल्कुल, ये तो आप जानते हैं ना कि चाहते सारे ही यही हैं कि परफॉर्मेंस बड़ी ज़बरदस्त हो, लेकिन जब इशू आता है तो उसके बारे में बात करने से ज़रूर टैबू टॉपिक के तौर पे ले रहे होते हैं और बात करना मुश्किल हो जाता है। हमें लगता है कि बात करना मुश्किल है, लेकिन पेशेंट ये बात करना चाह रहा होता है। ठीक है, तो असल में ये उसके ऊपर हम, क्योंकि पेशेंट अगर आपने देखा हो हमारे पास जो भी आ रहे होते हैं हम सब डॉक्टर्स के पास, वो डॉक्टर्स को खुदा के बाद नेक्स्ट उस पेडिस्टल पे देख रहे होते हैं। तो देन वो उनके सामने ये चीज़ पूछना उनके लिए बाज़ दफ़ा बहुत मुश्किल भी हो जाता है कि हम ये कैसे पूछें, डॉक्टर साहब नाराज़ ना हो जाएं, पता नहीं क्या है, चलो चलो ठीक है डायबिटीज़। जैसे आप खुद देख लें कि अगर कोई कॉन्डोम या कोई दवा आप खरीदने जा रहे होते तो आप खुद पैनाडोल साथ में और बाकी दवाई कैसे खरीदना शुरू कर देते हैं कि ये भी साथ साथ चाहिए। ठीक है, सो दैट्स द रियलिटी। अब इस सारी पोजीशन में अगर देखें तो ये एक समझ लें कि एक्साइटमेंट और एंग्जाइटी के बीच का सफ़र है कि मुझे परफॉर्म भी करना है लेकिन एंग्जाइटी भी इतनी शदीद है कि अब क्या हो। आप सब लोग जानते हैं कि एंग्जाइटी के बाद आप वो इरेक्शन उस तरह सस्टेन कर नहीं पाता या जल्दी इजैकुलेट हो जाता है। सेक्सुअलिटी एक बहुत बड़ा टॉपिक है। सेक्सुअलिटी को सिर्फ हम इस चीज़ के ऊपर 5 मिनट की एक्टिविटी के ऊपर ख़त्म नहीं कर सकते। उसमें जैसे सर ने कहा कि मुख्तलिफ पहलू, डिज़ायर और बाकी चीज़ों के साथ साथ आप ओरिएंटेशन भी देखनी पड़ जाती है। हो सकता है उस इंसान की बाज़ दफ़ा हम कहते हैं ना, वो कहता है मैंने शादी करनी नहीं है लेकिन शादी हो गई, तो उसकी ओरिएंटेशन ही कुछ और थी एंड देन शादी हो गई। अब परफॉर्मेंस के एक और इश्यूज़ आना शुरू हो गए, हम चाहे कितनी भी इंटरवेंशंस करते रहें वो मुश्किल होना शुरू हो जाता है। कोमॉर्बिड मेडिकल इलनेसेस चल रही होती हैं, बाज़ दफ़ा अगर SSRIs चल रहे हैं तो उसके बाद भी डिज़ायर ख़त्म हो जाती है। आप सेरोटोनिन को बंद कर देते हैं, डिज़ायर ख़त्म हो गई, तो देन आप क्या करेंगे, डोपामिन का कुछ भी नहीं, वो चीज़ें भी हो रही होती हैं। तो जब तक हम बात करेंगे नहीं पेशेंट से तब तक ये चीज़ ओपन अप होगी नहीं। हाँ, बाज़ दफ़ा कल्चरल एस्पेक्ट भी बहुत ज़्यादा होते हैं। उसने सुन के क्या रखा है कि इतनी देर परफॉर्म करना है और इतनी देर परफॉर्म नहीं किया तो देन इट्स कुछ भी नहीं है, तो वो एक अलग पहलू है जिसको देखना ज़रूरी है। तो और उसके साथ साथ अगर चाइल्डहुड एडवर्स एक्सपीरियंसेस कैसे रहे हैं, उसका मैरिज की तरफ या ट्रॉमास की तरफ वो किस किस चीज़ों से होके गुजरा है, तो ये सारे पहलू इस सब एंड अप कर रहे होते हैं इस परफॉर्मेंस के हवाले से। तो दरख्वास्त मेरे जो कुलीग हैं उनसे सिर्फ यही है कि अगर हम सब जानते हैं कि कोई पैथोलॉजिकल कॉज नहीं है तो फिर हम कितनों को रेफ़र करते हैं। वजाहत साहब के तो पेशेंट्स बिल्कुल सर मैं देख रहा होता हूँ आते हैं, बड़ी मेहरबानी आपकी कि आप उनको सही बता देते हैं। हालांकि बहुत मुश्किल होता है पेशेंट को। एक और मुश्किल बात है कि अब आप भेजें कि भाई आप नफ्सियात के डॉक्टर के पास चले जाओ, एक और मुश्किल आपके पास टास्क है, लेकिन वो सारा टास्क जो है वो कम्युनिकेशन से हल हो जाता है। एक बेहतर कम्युनिकेशन से, रैपो से काफ़ी चीज़ें हल हो जाती हैं।
On the last point, what I have learned, just one comment, sir. Okay, never ever send your patient in the first visit to the psychiatrist, even if you think he's clear cut. Ask for some tests, prescribe some placebo, and in the next visit. Otherwise, his take home message is, उसने मुझे psycho label कर दिया।